I'm the director for pain management for the palliative care system with Legacy Home.
I'm Paul Coelho, director of pain management for Salem Health. And I was hoping that we could get the audience to identify who they are too.
Katrina Buse, pain psychologist in the Comprehensive Pain Center at OHSU.
Jim Shames, primary care, work for Jackson County Public Health and consultant for Synergy.
Hi, I am Kim Swanson. I'm a licensed psychologist and the director of behavioral health at Mosaic Medical.
David Labby from Health Share of Oregon.
Lisa Whitmore, I'm an NP from OHSU. I do adult inpatient pain.
I'm Kim Maurer from OHSU. I'm the director of the Comprehensive Pain Center at OHSU.
Hi, I'm Joe Thaler, and I'm the medical director of the Oregon Medical Board.
I'm Joe Schnabel, until recently the director of pharmacy at Salem Hospital, but as of about 2 months ago, the executive director of the Board of Pharmacy.
I'm DJ Lynch, a family doc from Medford, Oregon, with Sante and the medical director in that health system.
And who do we have on the phone? Task force members. I think I heard Michelle.
Yes, Michelle Marito, peer support specialist for chronic pain and person living with chronic pain.
Who else? Thanks, Michelle. I know we heard a couple of other task force members.
Yes, hi. This is Mark Cantor, pharmacy director for All Care Health.
Hey, Mark. Any other task force members on the phone? Okay, and then just so we know who else is in the room, so folks in the back, could you introduce yourself, Lisa?
Hi, I'm Lisa Shields with the Public Health Division here. Hi, I'm Sue Robb. I am from the communications office of the division.
Okay, and who else do we have?
I'm Paul Nielsen, Government Affairs for the House.
Thanks.
And I'm Sarah Aldrich with CCO Oregon.
Great, thank you so much. Thank you, everybody. Okay, couple of logistical items. I just want to remind folks that, as you know, these are public meetings. That mean, do we have somebody else just join? Hey.
Hi, Eve Klein from CODA and Oregon Society of Addiction Medicine.
And I'm going to let you not use the mic for that, but you have to use the mic in the future. It's okay, we got it. It's okay. You weren't here when I said you have to use the mic. So these are public meetings. That means we might have members of the media on the phone, other folks, so you could read about this in the paper. Just want folks to know that all of this is a public meeting. Just want to be sure folks understand that. That's important.
Have your own mic.
If you take a look at the agenda in front of you, we have some kind of preliminary items, and then we're really going to start talking about the guideline content today. So if you take a look, we're just going to briefly get an update on the HERC. This isn't on the agenda, but part of sort of the introduction, as well as I wanted to share some ideas for ground rules with you. Then we're going to review those principles for the guidelines that we came up with last time. An outline for what should be included in the guidelines, at least a preliminary one, and then we're actually going to dive into some content, and we have some ways to sort of start that discussion, and we're going to see how far we get on the guidelines. And when we get there, I'll talk a little bit about how I hope that we can have that conversation. Anybody have any questions on the agenda? I'm going to ask Dana to give us an update on the HERC work, that rhymes, just so that because folks had asked about it last time, and so we think it's important for you all to understand where they are and vice versa.
Great. So first, just appreciate the conversation we had about the HERC last time and acknowledge your interest and share that interest back of making sure information is flowing as you all do your work. You might have recalled when we met the first time, we were anticipating a decision made by the HERC on a chronic pain proposal in front of them. And you may have also heard that we subsequently asked to have a pause on that consideration at the last meeting. Just as background, the work on the chronic pain proposal in front of the HERC has been a work underway for nearly a year and a half, including expert opinion or expert input, public input, and of course reviewing substantial amounts of evidence. Late in the process, right before the last meeting, we came to understand there was a potential conflict of interest, and for us that was challenging just at the very last minute when a decision was being made. Director Allen asked that we pause the deliberation just to be sure we could have confidence in the proposal that it was created with objectivity and full transparency and in the best alignment with the evidence. So we asked the HERC to pause, which they agreed with, and we have a third-party contractor in place who is re-reviewing all of the evidence, looking at the proposal to see if there is alignment and identify where there isn't. And that information will be reported back to the HERC at their next meeting in May as they further their deliberation on the proposal. So happy to take information, but just wanted you to know that decision or no decision has been made, a pause in place, and that work is underway by our contractor. Alongside, we are also doing an up and down review of our conflict of interest processes within our agency, and particularly focused on the HERC to ensure we're following those so this doesn't happen again. There's been a lot of work put into this, and I think we all are in agreement with the process to take a pause, but want to make sure we move forward with the right processes in place in the future. Happy to answer any questions if you have them.
Okay. Thanks, Dana. The next sort of preliminary item, just wanted to take a look in your packet. I think it comes after last time's meeting notes. It just says ground rules for task force meetings. Last time we talked a little bit about ground rules, and what I heard from you guys is just send us something that you normally use, and this is something that I often use with folks, so you can take a look at them. They're very straightforward. There shouldn't be any surprise. It says ground rules for task force meetings. You guys have it? Okay. Anybody have any questions, comments, things you don't like, or things that are missing? I'll give you a minute or two to take a look at them. Any comments? Okay, so the idea is, and I have no expectations that it won't be anything other than this, but that we would use these ground rules as we have what sometimes can be difficult conversations. All right, the next thing we want to do is, and now we're starting to get into the work, is to take a look. So last time you all brainstormed principles for the taper guidelines, and what we talked about is sort of what, and it says draft principles for opioid taper guidelines, and they're from our last meeting. And what we did, just so you know, is we sort of tried to group them and reorganize them and put like things together. And the idea is this is, whatever guidelines we come up with, you all come up with, that they should, and we're going to spend a little more time working on this list, like they should meet this list, that these should sort of undergird the principles, the guidelines that you come up with. So I had a couple of questions for clarification, but I want to, again, give people a few minutes to look at. What we also included for you, and I believe this came at the suggestion of a couple of folks, is what are the other, folks have already thought through some of this on pain management, competencies for pain management, HHS pain management practices, and the Picker Institute's principles of patient-centered care. So we just wanted to provide those to you as resources, if there was anything else. But what I'd like to spend the next few minutes doing is hearing from you all about these principles, revising them, if you want to add any, if you want to take any out, and then I had a couple of specific questions when I saw that I wanted sort of clarification on. But let me give you again a moment to take a look at them. So let me ask my questions for clarification. As we talked about, it wasn't just mine, as we talked about it as a team, the two questions I just wanted to be super sure that we were clear on the meaning of is number 8, medically realistic, and what does that mean? Does that mean evidence-based? I mean, I'm just looking to you all to tell me what it might mean, and if it's duplicates, evidence-based. It was just, and we were all brainstorming, right? So we were throwing stuff up there, and so this is the time for revision. Kim or David? Yeah, can you use the mic? I'm so sorry.
I think it's a.
Oh, mic doesn't work.
Well, we've got several up here. We've got 1 or 2. We've got 2 or 3 up here as well.
Is it on? It's got to be red light. No, that doesn't seem to work either.
Here, this one's right.
You have to be smarter than the microphone. So I think that's a really, I was smiling just because I think that's a really subjective term. And what medically realistic to one is not to another. And it might not be aligned with what's medically realistic to our patient. And so I think that's vague. And when we were talking about evidence-based, I whispered in David's ear, like, what does that mean in this context? I think that's a tough one. And so I would move to strike that particular
medically realistic.
Yes, I would.
We got too
move
many.
To strike that.
Right. We're going to go right around the room. Go ahead, Minnie. Try it.
We're working to replace batteries right now. I'm sorry. They should be all
So
working.
you know what? Let's just all speak really loud.
Yeah.
So
I'll speak loud because I'm just starting off.
Go for it.
So I think what medically realistic would mean is based on the practice that you're in. So for example, in my practice, because we're setting up a program where our job is going to be taper people to a safe dose, we have the resources and the time. But if you're expecting a primary care provider to do it, where they have 10 minutes for a visit, then it's not medically realistic. So I think that medical realism comes based on the institution that you're practicing in your practice. So I think we need to be cognizant of that fact and also give people some sort of a leeway. So it has to come from the institution. So if the institution you're participating in or your practice has to give you that time, because a lot of practices, they're there because they have to pay the overheads too. Right. And so they can't spend an hour on each patient. So we have to be kind of realistic about that. That's the reality.
We're going to give up on.
You know what? They replaced that. I'm worried because there are no microphones over here from the speakerphone. So if we can maybe give it one more try. I know it's frustrating.
Yeah.
If it doesn't work,
okay, let's try it.
up.
We're going to keep trying.
You gotta wait a second too. You turn it on, red light. Stick it up your nose.
I'm going to come bring it to you.
The one next to
Those are the formal instructions for the
Does that work now? One next to you. Try that area.
Is this working?
Nope.
No.
Here.
How's that?
Yep.
There we go. So I think medically realistic number 8 and 13, I actually started both of them at the same time, and I wrote, how do we get insurers and systems engaged in supporting this mission? And I think that was really the nature of the discussion we were having using those terms. BJ had brought up, I'm in private practice, I'm in a rural area, insurers are paying for 15-minute visits. This is not a 15-minute visit, we all acknowledge that. I don't recall, but do we have anyone representing the insurance industry or the larger, OHSU obviously has a clear, large presence in the room, but CCO, okay. So I guess I would pose that question to you in terms of, we know what we medically need in terms of engaging in patients and doing this work. My question is how do we get the CCOs and how do we get buy-in from those stakeholders?
Well, mean, there's obviously not a simple answer to that, but there are CCOs locally that are figuring out payment models that will support this practice. So, I mean, I think that's part of value-based purchasing, and that's one of the goals of CCOs in general for the next iteration of CCO land. So, but I mean, how far down this rabbit hole do you want to go? But I think.
So I think
that is an issue.
I think the question of how you, to that point of sort of how you get payers involved or payers engaged and other, like to buy into a set or to adopt a set of guidelines, right? I think that's another piece of our work, or I don't know if it's, I mean, probably, yeah, it is. But I want to sort of bring us back to the idea of these principles, right? Do we think the principles, I'll just use 13 as an example, should be practical, right? Like, and again, these are just like, when you want to say the principles are patient-centered, the principles are compassionate, the principles, so if you think about that as the beginning of the sentence. Go ahead, Kim.
Yeah, and I just want to challenge the notion that primary care can't do it. They do it all the time. And well-resourced primary care that's integrated and has team-based care is fully capable of doing that. So medically realistic, again, to me, is in the eye of the beholder and vague, and it implies that if it's not medically realistic, we don't do it, and that kind of feels icky. And so I would just challenge the language around it, and if it needs more specificity, then I would invite that language.
Great. Katrina, go ahead. And then I have Eve, I know, had something to say.
Well, I think I'll just take a minute, because mostly I think it's already been said. I wanted to kind of build off what Minnie said, that so I thought medically realistic meant kind of a combination of realistic and practical, based not just in an organization's resources, but additionally in the community's resources, which speaks to what's supported by payers, what other referral options are available to that patient in that community. So there might be situations where somebody's really in a remote place and they're just not going to get access to best care there. So it would be ideal if we could make room for exceptions, but yeah.
And so that may come in the content of the guidelines, right? That you might have that. Let me hear from Katrina and then David.
I'm hoping, oh good, it does actually. Would you just wait a minute? So I'm only going to comment about what was in the other guidelines, but the question is, what's the purpose of these and who's the target audience? And with our other guidelines, both the acute and chronic, we realized that we have mostly primary clinicians in the room and some other stakeholders. The purpose of these guidelines is not just to tell clinicians you must do. It is also the purpose of these are as a communication tool to the general public, to others to know what to expect, and to health systems. And we definitely, in the acute guidelines particularly, called out what things health systems would do. So I think, whether it's a principle or not, but understanding that the purpose of these is not just focused on what individual clinicians should do, but what the system in terms of care. And I think that might help some of this discussion. So that would be in line with the other guidelines as well.
David.
I think what people are talking about, in part at least, is applicability to different practice settings. And that's so. What we want is, if these are guidelines, they should be applicable in somewhere to different practice settings. If we say that, then that's what it gets at.
Does that? I'm seeing lots of nodding heads. Okay. I told David today that he was one of my favorite meeting participants for last decade, and there you go. Applicable to different practice settings. That really, I think, captures it. Lots of nodding heads there. Folks on the phone, I want to make sure, Michelle and Mark, that you can hear us. If you can't, please let us know. If you ever want to jump in, please do just jump in. So what if we substituted number 8 and it says applicable to different practice settings? And then, is there anything else on these guidelines people want to change, clarify, add, delete on the principles? Because what I think we would do later on, we would come back when we have the guidelines. We would sort of use this as a lens. Does it meet these principles? Okay. All right. The next thing I want to move us to. Everybody cool with moving on? take a look at the next page. It says Oregon Opioid Taper Guidelines Task Force draft outline. If you recall, at our last meeting, we also, so much feedback. It's all right, I'm around. I'm right here. Okay, is that we talked about what should be in the guidelines. And again, the team took this and organized it. And here's what I'll say about it. We can definitely add to this and tweak it as we move forward, because we know some things will come up. But we try to get some of the big categories here. And so what I'd like folks to do again is to take a minute or two, look at this. And my question for you is this generally correct? Are there major holes that we need to fill? Again, this isn't going to be the only time we look at this, but it can provide some guidance.
Diana, can I add a quick comment?
Absolutely.
In terms of, I think, where to focus is the major categories with the Roman numerals. The subcategories was filling in some of the other things you guys identified in a way that we thought was organizationally appropriate. We know that in some of the Roman numerals there is nothing listed there. We know we're going to fill that out. So I don't want you to look at what's missing, but generally based on the input, this is the input you gave us, and this is how we suggest organizing it, and we'd love your feedback on that.
Nice. Do you have a packet? Great. So we're just looking at the outlines, and getting some feedback on that. We just we're in quarantine.
I know.
We're clustering away. All right, David, are you just holding the mic? You're holding the mic to be helpful. Who has comments on the outlines?
I have a comment. This is Michelle Marika.
Go, Michelle.
I think that this is really well covered and this is really well put together.
Great, thank you. Paul.
Is red?
Yeah, it's working.
Red's on.
Is it working?
Yeah, it's working.
Just, somewhere in the deep dive, hopefully we define the bandit.
Oh yeah, I think that's part of the idea, is that it's under definitions that we would have to define it. Yes, thank you. Abandonment. It's on here. Anybody else? We will use Kim, please.
I know this came up a lot last time when you mentioned it, but the difference between taper and wean, I think that that's an important distinction, and we don't have that in the definitions. I think that would be important to add. We also, Jim had brought up last time this idea around chronic opioid dependence that's not a use disorder. And I think that's kind of an emerging definition, but it might be important to add in there as well. So
it's gone.
It's gone.
It's actually it's F, letter F, opioid dependence. Your mic is not working.
Is this better? Okay.
Yeah.
Kim, just in response.
No, that's different. That's a different definition. Opioid dependence is different than what Jim. Yes, that's different than what Jim is describing. It's actually not a use disorder. It's just somebody that's
complex.
It's a different opioid dependence.
So it's actually the language referenced is in when we get into definitions. You'll see it in there. And how we parse it out is going to be up to you guys as we look at those definitions. Same with tapering versus weaning. We heard that loud and clear. Some of the tapering definitions we got from various resources talked about both in the same definition, so you guys can look at it and tell us how you want to move forward. So it's captured in the materials for us to dive into in a few minutes.
David.
There may be a category about when to refer. So what are the red flags that say this is really not something I should be dealing with? I should send to mental health, or this I should send to addiction treatment, or I should send to Paul, or I should send to Jim. That when to refer is really a scope of practice question, and it's different in different practice settings. But somehow I think it's just it also sends the signal that we're not expecting you to take every comer, every complex thing and do it. So I think that's really important.
Great. Great. Okay, so we're, Jim, did you have something?
I'm assuming that, as you said, we will get in. The only point about CPOD is that it is an emergent concept. It's people are starting to rally around it, and it has implications. So I'll wait to see how when we get into a deeper dive. But there is a distinction between chronic persistent opioid dependency and the concept of dependency. So.
Okay, yeah, I appreciate that.
I have one
Please,
comment.
Minnie.
So when we say weaning also means tapering. So weaning to offset, I would suggest discontinuation instead of weaning. So either you taper or you discontinue.
Great. Good. Okay. We will use this as our working outline, and we'll taking into account the additions that you all just made, and we'll change it as need be. But this is sort of the working outline. Okay. So we're gonna we actually have the rest of our meeting pretty much to talk about guideline content, and I'll tell you how we're gonna do that. We're gonna start digging in. On the agenda, we have 3 items to start with: definitions, patient assessment evaluation, and when to consider tapering. As I said, we'll see how far we get. I wanted to make a couple of comments about the team put together this document. It looks like this. It says discussion guide for 4/12/19 task force meeting. That's what we're going to spend the rest of our time referencing. And before we go there, I want to give you a little context. So what the group did was to take a number of reference documents, and we know these are not all the reference documents that are out there, right? But we know that we're not saying they're all equal in terms of evidence-based or adoption or anything like that, but we wanted to start somewhere. And so we used from the CDC, Oregon Pain Guidance, the VA, the Washington Agency Medical Directors Group, and the DSM manual. And so we wanted to give you some resources, and a couple things I want to say. First, on resources is we've asked you all for additional resources and guidelines, and some of you have given us some, and that's been really helpful. And what we're really looking for primarily are other guidelines and relevant articles about tapering. That said, if there are other materials that you think, this is not exactly one of those 2 things, but they're related, please let us know. And what we're going to try to do is sort of sift through that stuff, and so not overload you, but also make sure there are resources available to help you all have this conversation and make decisions. We're really trying to manage that group of resources. Did you have anything you want to add to that, Dana? And then the other thing I want to say is this is a first pass, right? This is not like we're going to have this conversation, we're going to go away and do some work, we're going to bring it back to you, and it's just going to be an iterative process. And I think, and so the thought is that we want to look at, so for just to look at the tapering definitions, right? We have to define tapering. Now we offered, these are what 4 different sources say, and you have a number of options here, right? You can say, the group could say, we should just adopt that one, and then we can talk about it. You could say, I like that one, but I want to tweak it a little bit. Or you might say, there's one I know that's not on here, and it's this. Or you